Welcome everyone to the I Have Neck Pain, What Are My Options webinar. This webinar is part of our series Chronic Pain, Improving Life While Living It, and we're glad you're here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by CIRPD, ourselves, and Pain BC in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya, and I will be moderating and managing the Q&A session today. And our presenter is Jordan Miller. Jordan is a registered physiotherapist with an interest in all areas of persistent pain, including neck pain. He is currently completing his PhD at McMaster University, investigating treatment of persistent non-cancer pain. Specifically, he's interested in the effectiveness of a treatment strategy that includes teaching people with pain about the physiology of pain and about self-management strategies to assist in reducing pain and resuming participation in activities that are important to each person. Thank you very much for being with us today, Jordan.
Thank you for that introduction. Thank you very much for having me. I thank CIRPD for this great service, and I'm excited to talk to everybody today a little bit about neck pain and some treatment options that are available for people with neck pain. I think it's always important to have a good understanding of the person who you're listening to, and I especially appreciate the introduction because I carry with me a few biases that should be brought up right off the get-go, and one is that I'm a physiotherapist, and so I have a tendency to favor movement solutions for persistent pain and for people with pain. Second, as a pain researcher, I'm interested in a few areas, and one of which is self-management. So I have a tendency to favor options that involve giving the locus of control to the people who are experiencing pain. And secondly, I'm interested in an area of research that we call knowledge translation. And knowledge translation is essentially about translating the evidence from research to the people that need to use that information, and that's what I hope to accomplish some of today. In speaking with you. So an outline of what I hope to accomplish over the next 50 minutes or 45 minutes is describe a little bit about who experiences pain, why we might experience neck pain, some of the factors that contribute to the complexity of neck pain, and what, as the title of the presentation suggests, what are the treatment options and what are some of the potential benefits and risks associated with those options. So to start with a question of who experiences neck pain, the answer to that question is a lot of people. 1 out of 3 adults actually experience an episode of neck pain each year. Many of those 33% of people report the neck pain as disabling, meaning it interferes with their day-to-day activities. And this matches up with the evidence that suggests that people with neck pain require more treatment visits with a physician and miss more work days in comparison to other people that aren't experiencing neck pain at the time. So there's a burden here both to the individual and to the healthcare system with people that are experiencing neck pain. So it's important that we find some options to help reduce the suffering and increase the abilities of people that are experiencing neck pain. So taking a little bit of tangent because I didn't want to just talk about treatment options for neck pain, but also a little bit about pain itself. So posing the question to yourself for a moment of why do we experience neck pain, and if this is your first CIRPD webinar, that it might be a novel question, and if you've been to a few throughout the series, I think you've probably been introduced to this topic by a few other speakers in the past. But pain is a protective mechanism that your brain uses to protect you from a perception of threat or damage. And I've asked this question of why do we experience pain to thousands of people over the last several years. And the most common answer I get is that it's to tell you that something's wrong or that something's been damaged. And that's not probably the best definition of pain to work with. And just like it's not the best definition of pain, it's probably not the best definition of neck pain. And pain is only one of many protective options that our body may use to protect us. For example, tightness or muscle spasm, weakness, getting out of that situation, stress responses such as changes in your endocrine system and immune system. All of these things are protective mechanisms that our body uses in response to stress, including pain. The International Association for the Study of Pain definition of pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. That's a very loaded definition, but 3 key points that I like to draw from that definition is that pain's unpleasant, and neck pain is unpleasant, and it has to be. Your brain is sending a message that to protect you from a certain stimulus or a certain motion, for example. And if the pain weren't unpleasant, it wouldn't be as big a motivator to make you change that behavior. Pain is an experience, and just like any experiences, your past experience is going to influence the present. So those of us who have had pain for longer than a few days have experience with that pain, and that's going to change our current perception of the pain or of the stimulus. Pain can be associated with actual or potential tissue damage, and I'm going to build on that idea a little bit before I switch into neck pain specifically. So the first is with a video. I've got the video muted, and I understand it might be a little bit choppy on your end, but I think that the message of the video will still come through regardless of whether it's choppy. So this woman, and this is a courtesy of BBC2, so you can Google to look at it later. This woman attends a fairground setting, and she's being set up outside of the screen. So it's set up in a similar position so that it looks like the rubber hand is her own hand. And all she can see is the rubber hand. She can't see her own hand. And then what this gentleman is going to do is stroke her hand and the rubber hand simultaneously with a paintbrush. They're going to repeatedly stroke the fingertips. And over time, her perception of that rubber hand is going to be that it feels like her own. That rubber hand is going to feel like her real hand. And this works on everybody. It's no exceptions to the rule. I've had this experiment done to me on a number of occasions. It's a very bizarre feeling if you haven't experienced it before. And now all of a sudden, without warning, this gentleman's going to attack the rubber hand with a hammer. And you can see the response on the woman's face is a response of startling. And in this setting, it's a bit of an artificial setting with a fairground setting, but some colleagues of mine are doing research in this area where in a laboratory they're not only asking the person what they experience when they attack that rubber hand, but also they're looking at their brain using fMRI images, a detailed image of of where activity is happening in the brain. And what we notice is that many of the same areas light up, whether that's a real threat or whether that's a rubber hand. So in that example, it's one extreme example of when we can have pain without having any tissue damage. There's no risk for damage there at all, as that hand's made of rubber, and there's no tissue to be damaged. But when you ask the person on the other end of that hand, or that's feeling like that rubber hand, they'll describe it as if it's a real pain experience that they're feeling. So that's one extreme end of the spectrum. But that's not, the other end of the spectrum can take place as well. So imagine for a second that 2 people experience the same whiplash injury. They're both in a car accident, and their neck and head do the exact same thing, going through a motion of whiplash. And now imagine for a second that one of those people, well startled and obviously injured due to the mechanism of the injury, when it was all said and done, they were sitting in their car and they were safe in that situation. Now imagine for a second that a second individual, their gas tank got ignited and they were in a fire and they had to escape that situation all of a sudden. Think for a second about who would experience more pain in that given situation. Would it be the person that was safe in their car, or would it be the person that had to escape that situation to get away from the fire? The answer to that question is probably the person that was safe in their car after hitting the tree. The person that's in the car that has to get away from the fire, their brain is probably going to prioritize something else in that situation. So they have to get away from the fire, and the priority isn't probably going to be to protect the neck, it's going to be to protect the whole person. Pain is a protective mechanism that way. It's a survival strategy, and when there are bigger survival issues at hand, the brain is likely to block that signal and tell the danger signal that I don't need to listen to you right now. I got more important things to think about. So there's an example of when we can have tissue damage, the same injury from one person to the same neck injury from one person to the next, but based on the context of the situation, the response might be very different, and in one case they may not have any pain at all. Now imagine that same neck injury, two different situations again. A person that experiences that neck injury is a physiotherapist who occasionally from the comfort of his own home delivers webinars. The other is a truck driver who has to drive long distances, check his blind spot regularly throughout the day. One of the symptoms of the neck pain is that they can't turn their head one direction. Who do you think is going to experience more pain in that situation? The answer is probably the truck driver. I would probably be able to continue to work if I had a whiplash injury and wasn't able to turn my head one way, but the truck driver may not. So thoughts that are going to go through the truck driver's head include, am I going to be able to go to work this week? They may include, am I going to be able to provide for my family? How am I going to get home? How am I going to see my kids? Those things might all play a factor in whether or not a person experiences neck pain after that injury, and if they do, how intense that pain may be. A third example of how neck pain is dependent on the context involves two people that are painting a ceiling. They're both doing it as part of their job, one of which, when they go to their employer to tell them about the injury, the employer is going to say, oh, you're making it up. You just want to get out of that job. You're sick of painting ceilings. Get back to work. The other person, when they go to tell their employer about the injury, the employer says, oh, that's too bad. If we can put you on for a job until your neck gets better, we'll do that. If there's anything we can do to help you get better, let us know what we can do to help you get better. In that situation, who do you think experiences the most pain? The answer, of course, is the first person, the person that's not listened to and told to ignore their pain and told that they're making up their pain is probably going to experience more pain in that situation than the other individual. Part of the pain experience is being able to share that message and being able to communicate. There'll be some emotional frustration secondary to the response of the first employer. And the relationship between stress and emotions and pain is a very real physiological connection, and that also contributes to the likelihood that that first person experiences more pain than the second person. And the fourth and final example of the context of pain that I wanted to describe is a study that looks at three groups of people, and all three groups of people are going to receive the same electric shock. One group ahead of time is told you're going to get a high-intensity electric shock. One group's told you're going to get a moderate-intensity electric shock. And a third group's told you're going to get a low-intensity electric shock. When the shock comes, even though it is the exact same stimulus between all three groups, who experiences the most pain? The group that's told you're going to experience the high-intensity electric shock experiences more pain when the shock comes than the group that's told it's going to be a low-intensity electric shock. So expectations play a role in pain. People that have a higher expectation of pain are more likely to get the protection from their brain in that situation when the stimulus actually comes. So hopefully from all of those situations, a couple of things that I wanted to accomplish is one, to break down the perception that's very common that there's a linear relationship between the amount of tissue damage in a neck injury and the amount of pain somebody experiences in a neck injury. And the second is to help build the idea of how complex pain is and how many inputs there are into the system that can influence whether or not you experience pain and how intense that pain is. I wanted to go through a quick session, and I think, again, for people that have attended previous CIRPD webinars, some of this may be review, and that's okay. But I wanted to go through a quick overview of the pain system. So if we start out at the tissue, where we have a picture of a woman grasping her neck, in our neck, we've got sensors that are responsive to various inputs. We've got sensors in our skin, in our joints, in our muscles, in our bone. And those sensors, if stimulated with high enough amount of stimulus that they get turned on, might send a danger signal up to our spinal cord. our spinal cord in the center of our neck. And in the spinal cord, the first nerve junctions with a second nerve. And that second nerve runs up from the spinal cord up towards the brain. If those danger signals come in, they might activate the second nerve and send the signal up towards the brain. But it's not that simple at the spinal cord, because we've also got descending input coming down that might increase the likelihood the danger message gets sent, or input coming down that might decrease the likelihood that that danger message gets sent. So in the example of the person that has to run away from the fire in the car accident, the signal being sent down to the spinal cord is probably going to decrease the likelihood that they get that danger message. They're going to block that. The brain's going to block that signal because it's got more important things to think about. On the other hand, the longer pain persists, there tends to be more activity in the descending pathway that increases the likelihood that the danger message gets sent. So the same danger signal coming in is more likely to be relayed up towards the brain the longer that pain has persisted, in most cases. An analogy that that I've stolen, and I can't remember who I've stolen it from at this point in time, is that the spinal cord is kind of like an amplifier in your stereo. And in the case of persistent pain, the volume on the amplifier is turned way up. So we could have the same input coming in from a record player or CD player or iPod, depending on which generation of music you listen to. And in the case of persistent pain, because the volume's turned way up, the brain's going to receive an amplified signal. So even if it's no more dangerous of input, something as simple as turning your head, your brain may decide to protect against that because of the volume of the message that it's receiving about how dangerous that is. When or if the message reaches your brain, it gets even more complex because that message is relayed to a number of locations within your brain. And because all of those different areas are involved, your thoughts can have an impact on pain. Like the person that has a high expectation of the electric shock in that study. Emotions can have an impact on pain, like the person that's told by their employer that they're making it up. And stress levels can have an impact on pain, probably a relationship that we're all familiar with if we've had pain for a long enough period. And the brain's left to conclude, given all of this information coming in, what do I do about this? What's the best response in this given situation? And if its response is to protect the neck, it may output pain or tightness or weakness, any of those responses that may happen in response to the given stimulus. So it's maybe not a surprise then, complexity of how many things can influence pain, that we don't really see a lot on an image that actually correlates well with pain. So in the research looking at what we find in healthy populations in neck pain, if we took an MRI of 100 people without any neck pain, no neck pain at all, we would find 73% have a disc bulge at least one level. 50% have a disc protrusion at least one level. 37% have an annular, meaning part of the disc is torn. Over 50%, again this is dependent on age, but have osteoarthritis. And none of these things actually correlate very well with pain. That's not to say that imaging is useless in the case of neck pain. In the case of progressive radiculopathy, meaning progressive symptoms that are continuing on or getting worse that go down your arm, like numbness or weakness, then an X-ray or an image might be warranted. And if there's a suspicion of a fracture, X-ray or another image might be warranted. But for the vast majority of cases, an MRI or an X-ray probably isn't going to tell us a whole lot about that person's pain because these things are so common both in populations of people with neck pain and in populations of people without neck pain. In fact, there was a study in low back pain that looked at one group of, both groups were equal in terms of what their injuries were, and one group, soon after the injury, were given the results of their MRI findings. The other group had the same MRI taken, but they weren't given the results of their MRI finding. And the group that was told the results of their MRI finding did much worse. They had poorer functional outcomes, and they had more lasting or persistent pain. So telling people that they've got a disc bulge or an annular tear or osteoarthritis can be scary if it's not accompanied by information that is helpful, like this information about how common it really is, and that it's probably not the sole cause of pain, because structural things such as these on findings aren't generally amendable unless you're an orthopedic surgeon, in which case they still may not be amendable, or a neurosurgeon. So that was a quick introduction on the complexity of neck pain. Now we're going to talk a little bit more, shift our focus a little bit. And first I thought we'd talk a little bit about what is currently being done for people with neck pain. So I'm a member of a group we call ourselves a Cervical Overview Group. We're a research group that does a series of systematic reviews on neck pain and treatment options for neck pain. And the results of those reviews have suggested that an approach including exercise for sure and perhaps the addition of manual therapy may be the best approach for neck pain. That's where the strength of the evidence tends to be lying. But when we look at practice patterns, current practice pattern in a study by Good and colleagues, my reference doesn't seem to be up there, we actually see that there's overutilization of some things, such as diagnostic imaging, narcotics, and physical medicine modalities, such as ultrasound or TENS. And there's underutilization of therapeutic exercise, which is where the bulk of the evidence lies. Now, this is not meant as a critique to any individual healthcare providers, because I think there are various reasons at a system level and healthcare provider level and a patient level as to reasons that this gap exists. But what it does tell us is that there's a gap between what the evidence is telling us currently and what's actually being done in practice. And I think that there's a number of things that we can do to try to work on that. And that's where I think knowledge translation comes into play. And two strategies that I'm working on to try to help with that is educating patients with things like a patient decision aid to help make it what treatment to get for neck pain. And also a clinical toolkit where we aim to provide the information to clinicians. So why use a patient decision aid? This maybe goes without stating, but I think patient-centeredness is important to make healthcare decisions with the patient's wants, needs, and preferences in mind. A large part of evidence-based practice is incorporating what the patient's goals are and what the patient needs and prefers. Patient decision aids have been shown to help with this. They've been shown to increase people's involvement in decision-making, improve knowledge of outcomes, and improve the value-based choices based on what the values are of the person with neck pain. I apologize for using patient language. It's not necessarily what I would have chosen to use, but I think when you're using the term patient decision aid, sometimes it comes out of my mouth without thinking. I would prefer use people who are experiencing neck pain. And I think there's no evidence in neck pain yet about the use of patient decision aid, but when patient decision aids tend to be most helpful is when there is both a potential benefit associated with the treatment and also a potential risk associated with the treatment. And in some of the qualitative research that we've just done over this past year, people with neck pain expressed to us a need for useful information that they felt like they weren't receiving at the time, and also expressed concerns over the side effects and risks of specific treatments that they were being recommended, specifically the increasing media presence discussing the risks of neck manipulation, and also in the use of medications that are also associated with some side effects. So I thought it might be appropriate in this case that I try to create a patient decision aid to try to help inform that decision based on what evidence we do have to help with that decision. Now, there's a working group that have developed patient decision aid standards, and they list several things that are really important to being able to make an informed decision. And I thought we'd take a kind of walk through using the patient decision aid in order to go through those. The first So that's a picture of the patient decision aid, and there is a link at the bottom of that. So this will be posted after, and you'll be able to receive that link. But also, it's easily searchable. So if you go to physio-pedia.com, and there's a search engine on there, and you can type in neck pain decision aid, and it will show up for you. But it'll allow you to use this on your own after. As a side note, and not the topic of today's discussion, but I know that there will be a percentage of people listening today that are clinicians. This information is also provided for clinicians at the same site, that the difference being that it provides a a little bit more information on the specific dosage of different exercise and manual therapy strategies, along with the techniques that were used in different studies to help you inform your decision making. So the first piece of information that a patient decision aid needs to provide in order to make an informed decision is a description of the condition. I think I've spent enough time today already discussing the complexities of neck pain and some of the many influences, things that can influence neck pain. So I'm going to move on to the natural history of the condition and what we know about what happens. Kind of a way of speaking about natural history in a little bit more normal language is what happens if I don't get treatment? What happens if my decision is I don't want to seek care? And first you have to lead that with the caveat that everybody's experience with neck pain is different. And so when we look at research and applying that to an individual, it's challenging to apply population data to an individual person. It doesn't always work perfectly. But with that said, if we are to play the averages, most people with what we call non-specific neck pain, meaning there's no symptoms down the arm, there's no associated headache, they experience decreases in pain and disability during the first 6 to 7 weeks after the pain. So on average, the person's pain goes from a 6 out of 10 to a 3 out of 10 within 6 to 7 weeks. And their rating out of 100 of disability goes down from 30 to 17. So substantial increase, but also a substantial portion of people that continue to experience pain. After a whiplash injury, what we know is that the trajectory is that most people do most of their improvement within the first 12 weeks after a whiplash injury. So the average person, pain decreases from a 4 out of 10 to a 2 out of 10 by the 6-month mark, and from a 4 out of 10 to a 2 out of 10 in function or disability after a whiplash injury. But the majority of people, I think it's important, the important take-home message is that the majority of people have had a large amount of improvement by that 6-month mark. So we're pooling data from some studies that look at 3-month recovery rates and some that look at 6, but they weren't substantially different. So 5 out of 10 people have completely recovered within the 3 to 6 months time frame, so about 50% of people. 3 to 4 out of 10 people mild to moderate pain at the 3 to 6 month mark. And only 1 to 2 out of 10 people continue to have more severe or disabling pain at the 3 to 6 month mark. So the message there is that the majority of people do get better, about 50% completely better, and then another large percentage of those left only continue to have mild symptoms. So as a little tangent away from the patient decision aid for a second, we can summarize that information by saying some people get better and others don't, which begs the question, can we predict who does recover and who does not? And the answer to that, of course, is not really. We can't do a very precise job of that, but we do know some factors that, again, on the population level, tend to predict who goes on to experience persistent pain and who doesn't. So predictors of a poor outcome following a whiplash injury include higher levels of pain intensity at the onset of the injury, higher levels of disability at the onset of injury. Of course, presence of headache, neck pain, or low back versus somebody that doesn't have those areas of pain at the time of the injury are more likely to continue to experience pain. High levels of catastrophic thinking, which is a person's tendency to have negative thoughts or negative cognitions surrounding the pain experience. So they might picture that the pain and disability has a larger impact on its life than somebody that doesn't tend to have those types of thoughts. People with depression or anxiety tend to have be more likely of persistent symptoms. People of the female sex without lower post-secondary education, and people with symptoms running down their arm after a whiplash injury. All of those things are predictors of being more likely to fall in the 1 to 2 out of 10 that continue to experience symptoms after the injury. Again, these things aren't necessarily extrapolated to individuals, but on a population level. There are some predictors of a positive outcome, and both of these things is that they're both adaptable factors versus some of those in the predictors of a poor outcome. High expectations of recovery or high expectations of treatment success are predictors of treatment success. So understanding some of the information that we've shared about the fact that majority of people can get better, and showing some of the evidence that we'll show shortly about the impact of, or the ability of treatment to change neck pain can have a positive influence on the outcomes. Also, wearing a seatbelt is an easily modifiable factor that has a positive impact. Interestingly, there are a number of factors that were looked at that aren't at all related to the outcomes of who goes on to experience persistent pain. Most notably there, the collision doesn't appear to have anything to do with the outcomes. Higher crash volumes and the type of collision appear to play no bearing on who goes on to experience persistent pain and who does not. So moving back to the patient decision aid to end my tangent there of predictors, now we want to move on to the description of treatment options. And to lay out the options as we do in the patient decision aid, we've got a number of options. And you'll notice that I group everything except for manual therapy and exercise into one category. And outside of my own bias as a physiotherapist, there are other reasons for that, in that the strength of the evidence tends to lie in those approaches. And I'll walk through that here. So the icon is the international collaboration of neck pain, where we're performing a series of research studies that look at all the research that exists and all the high quality research that exists in the area of treatment of neck pain. And you can see that there's been a number of treatment options out there that have been investigated. And if we break it down on the type of neck pain at what we're looking at, now these next few slides are going to be a little bit confusing because there's a lot of information in them. And that's okay. I'm just going to walk you through them using my voice, so try not to get too overwhelmed by the symbols and the colors. In the acute whiplash, manual therapy and exercise and education video show some promise, whereas ultrasound shows no difference. In subacute or chronic whiplash, Botox has shown no benefit. We have little evidence in whiplash, but if we look at nonspecific mechanical neck pain or nonspecific neck pain, we see that we have a lot more evidence to inform our decisions on. The top two are both manual therapy and exercise approaches, and I'll go through the evidence of those more specifically later. Nerve block injections for somebody with facet joint pain specifically, which is a difficult criteria to diagnose because it takes an injection to diagnose it first, shows some positive long-term effects. The things that show short-term benefit involve a certain type of exercises, laser therapy, acupuncture, and traction. So all of those things can provide you short-term benefit, but there's no evidence that they're going to make any long-term difference in your recovery. We've got a number of things that have shown no benefit, and that includes, again, Botox, injections, ultrasound, infrared red light, heat, and continuous traction. So all of these things are things that aren't showing any benefit in the treatment of neck pain. And finally, with neck pain and cervicogenic headaches, we see another common theme is that there's a combination of manual therapy and exercise seem to show some treatment benefit in the long term. And with neck pain and radiculopathy, we really have a lack of evidence here. We only have short-term benefit of intermittent traction, and we don't have a lot of evidence beyond that to guide us. So that was a lot of information, not meant to be overwhelming, but meant to back up our decision in presenting where the quality of evidence is, because if we're looking at long-term differences or things that are going to make a long-term difference in neck pain, there seems to be a strength of evidence surrounding exercise as the main component. So to move on to how the patient decision aid presents that information, it tries to present it in a way that's easily understood by somebody without a healthcare background. The first neck pain you have, or select what type of neck pain you have, because it's important to look at the data that most closely, or the results of the research that most closely associates with your neck pain. So for an example to walk through how this might work, and again, I encourage you to do it for yourself afterwards, I'm going to try to pick the category that would suit the most people of who I anticipate is listening on the other end of this webinar, and that would include people with nonspecific neck pain for longer than 12 weeks, so people with chronic nonspecific neck pain. Manual therapy and exercise, again, we've got a few confusing slides, so I encourage you to read through it again after, but we've got two categories on the right side And the one is a series of 10 faces. They can either be smiley faces or frowny faces or neutral faces. And the number that are lit up is how many people out of 10 would experience a significant improvement with this treatment approach in comparison to the comparison treatment. And the sliding scale on the right suggests how much improvement the average person would experience. So it's a way of presenting research results in a way that's hopefully fairly clear and concise, is our goal anyway, although we haven't tested that yet as to how clear it actually is. So manual therapy and exercise appears to provide a short-term benefit over exercise alone, but no long-term difference in pain or function. And exercise provides greater short and long-term improvements in pain and quality of life in comparison to manual therapy alone. Excuse me. Manual therapy and exercise provides greater long-term improvements in pain and function in comparison to advice, which a larger effect size in that case. Exercise alone is also effective in both the short and long term in improving pain and function. But when we look at different types of exercise, we recognize that exercise can't just be focused at the arms and shoulder. It seems to have to involve movement at the neck. And when we look at comparing two different manual therapy approaches, manipulation, which is a faster, higher velocity, meaning faster movement, that might be involved with a pop or a crack, and a slower mobilization. And it appears that those two treatments are of equal effectiveness according to the limited number of studies that have looked at it. We've also, in informing decision, we have to look at not only the potential benefits of each treatment option, but also the evidence of risks associated with each treatment option. So what are the risks when we look at this? With taking on an exercise approach, there's 3 out of 10 people will experience some mild increases in pain or perhaps tingling or perhaps dizziness. So we call those transient increases, short-term increases. If we look at neck mobilizations, again, 2 out of 10 people will experience a temporary increase in neck pain with that type of treatment. And 1 out of 10 people would experience some neurological symptoms such as pins and needles sensation or tingling sensation. If we look at neck manipulation, they're similar. 2 out of 10 increase, 2.5 out of 10 increase in neck pain, and a 2 out of 10 increase in likelihood of experiencing those pins and needles or tingling sensations. There's also, with manipulation, some very rare but serious side effects. For example, unbearable symptoms, which happens in approximately 1 out of 10,000 cases. And stroke or death, which is a really hard number to estimate, but definitely less frequently than 1 out of 10,000. But we don't really have an accurate estimate as to how that's the case. And it's those that get a lot of the media attention, which had a lot of the participants in some of our research concerned about the potential side effects. So that's a lot of info that gets thrown at people in the patient decision aid. But if I summarize that as briefly as I can, manual therapy and exercise, the combination, provides greater short-term pain relief than exercise alone, but no difference in pain or function in the long term. Manual therapy and exercise provides greater short and long-term pain relief in comparison to manual therapy alone. And exercise is effective on its own. And manipulation and mobilization appear to have similar effects. Manual therapy and exercise are both associated independently with a risk of short-term increases in pain or worsening of current symptoms. And manipulation has an added risk, even though it's very small, of a more serious side effect, or like stroke. So a choice has to be made here, and this is where a patient decision aid becomes helpful, because most people, I think, given the risks and benefits of exercise, would probably choose a movement solution if informed on the potential benefits and the potential risks. But where it becomes an individual decision is whether or not to accompany that with a manual therapy approach. Some people may choose to accept the added risk of short-term pain in order to receive the short-term benefits of reduced pain. even though there are no long-term benefits associated with the hands-on approach according to the evidence. Others may choose to take the small but more serious risk of a manipulation for the short-term pain relief. Although perhaps given the information of equal effectiveness of manipulation or mobilization, some of those people that would choose the manipulation may change their mind, given that there's no added and that there is a risk associated, however small that may be. And the last criteria that the standards suggest should be included in a patient decision aid is asking the patient to consider their own values when making a treatment decision. I think this is a really important one that often gets left out of the healthcare decisions when a person with neck pain and a healthcare provider are collaborating to decide what treatment approach they're going to take. So an example of how this patient decision aid would ask you to consider your own values is asking, how important is it to you to get that short-term pain relief? How important is it that you have long-term changes in pain or function? How important is it to avoid potential side effects? Whether it be the more common ones of temporary increases in pain, or whether it be the more severe ones of long-lasting pain or catastrophic side effects. So I think there's, and other factors obviously that inform the decision involves cost of care. Treatment isn't usually free, and usually is associated with a cost. So those are values that have to go into the decision on whether or not to seek care. But hopefully, walking through that patient decision aid, you would feel more informed about making that decision and being involved in the decision. Actually, as a clinician, one of my least favorite patients to work with is actually a passive healthcare consumer, somebody that comes in and wants you to make the decisions. Because I think in our new world of healthcare, I don't think that we should have very many passive healthcare consumers anymore. I think we should be informed, and that people that are experiencing the pain should be the ones that are most involved in making the decision, because they have the most at stake. So I thought I'd summarize by saying what I would do with nectar. This is the most appropriate way to conclude, but I'll go through my own decision making on what I would do. If I had an acute episode of neck pain, I would educate myself on pain neurophysiology. I'd take the time to gain a better understanding of pain, because the evidence is showing, repeatedly showing, especially in other areas, not necessarily the strength of the evidence in neck pain, but the evidence is suggesting that people that understand more about pain tend to do better. They tend to experience better outcomes of other treatments, such as movement solutions or therapies. I would keep moving and stay as active as I can in my usual life activities, because people that stay moving and continue to participate in their lives tend to experience better outcomes. And perhaps most importantly, I'd be confident that I'll get better within 12 weeks if I keep. I think having the positive expectation of a recovery within that 12-week timeline, understanding the evidence around that area to suggest that's true, increases the likelihood that I would have that that I would experience that improvement. If I have chronic neck pain, my thought process might be slightly different, but I think I'd summarize it by saying I'd arm myself with as many tools for self-management as I can. I'd include a set of exercises to perform regularly in that repertoire of self-management strategies. That may involve me seeking help, again, bias disclosed, as I am a physiotherapist. Might get help from a physiotherapist if I'm not confident in my own abilities and knowledge of which exercises to perform for neck pain, because there are some exercises that appear to be more effective than others. For example, upper extremity and exercises alone didn't seem to do the trick in a couple of studies. I would not choose a hands-on or passive approach to my treatment. I would not ask for any modalities, such as TENS or ultrasound. I would make this decision knowing that they're not likely to make a long-term difference in my outcome. That's not to say that everybody would make the decision. It is a personal one. but I think I would want things that give the locus of control to me, that give me the tools that I need to enhance my own recovery and take the steps necessary to either reduce my pain or improve the quality of life I can live despite my pain. And I would consider other factors that may be contributing to my pain and try to address those. So if I'm overly focused on my symptoms, I might try to book my schedule a little bit busier and keep track of what I'm doing, schedule a weekly routine in order to encourage more participation and focus, engage my attention on things that aren't related to my pain. If I were stressed, I might try to break the cycle of stress and pain by participating in something that I enjoy every day, having a strong supporting network around me of my family and friends. If I were depressed or anxious to a certain level, I might seek care from my family physician or from a psychologist or from a counselor. And most importantly, again, I would stay active and involved in all my usual life activities, because the evidence suggests that people that stay more active and more involved tend to experience better outcomes. So that's what I would do if I had neck pain in each of those cases. There are a few people I'd like to acknowledge before I open up to questions. And so as part of our ICON work, which I used as the evidence for this patient decision aid, I have to recognize the Cervical Overview Group and Cochrane, where we publish our systematic reviews, our university partners of McMaster University and Western, and CIHR in helping support that, and Hermosa Physiotherapy and the actual production of the patient decision aid. And lastly, again, I'd like to thank CIRPD for the opportunity to speak today. I really enjoyed having the opportunity to share some of what we've been working on with the people who would benefit from hearing the information most. I hope it's been valuable and that you've been able to take something out of today that helps you in planning on how you're going to move forward, whether you have neck pain or whether you treat people with neck pain, or whether you have another area of pain in which you can use this information to help benefit you. So thank you very much.
Great. Thank you very much, Jordan. That was a very great presentation. And I do have a couple of questions. One of the big ones is asking about differences in what type of manipulations you're talking about. Chiropractic, more like often, at least in my experience, and what's a couple of people are saying, more what you get at physiotherapy, which tends to be more of a minor, gentle manipulation, versus massage, versus myofascial release. There's just a couple of, what would you say is the difference between the manipulations that cause more damage and have higher risks?
Okay. I think that's a very great question, and one I probably didn't spend as much time as I should have throughout the presentation. So manipulation versus immobilization first. A manipulation is a high velocity. It's a thrust movement. Usually they're trying to cavitate a joint, meaning create a pop or a crack sensation with that approach. And immobilization is a lower velocity, a slower movement, or a slower mobilization still aiming at the joint as the tissue that most people are picturing that they're moving in that case. I try not to differentiate between healthcare professions, because I think we put ourselves at risk in generalizing what professions do to an individual within that profession. But as one statement I think that I can confidently say is, in echoing what your own experiences were, is that if we look at the number of manipulations performed by a chiropractic profession versus the number of manipulations performed by a physiotherapy profession or a massage therapy profession, then I think that they're a much larger part of the practice of a majority of chiropractors. Now, when that comes to risk, speaking of benefit and risk, again, there's no evidence that there's increased benefit of the manipulation over the mobilization. The evidence suggests that they're of equal effectiveness, at least the evidence that we've got as of today. But it does suggest that there's a slight increase in risk, very small, but nonetheless present with manipulation. So again, that's where I think, and I don't think it's happening on a frequent enough basis, that people need to be informed of what the benefits are and the risks are before they make the decision on whether or not they want that type of treatment. I think that they have every right to choose that that treatment, and some may still choose to do it, but I think it should be an informed decision. The second part was regarding massage therapy, and myofascial release was, I think, the other one. And I would say that gentle handling strategies have a lot of potential too. And I wouldn't tend to differentiate between professions, but say that I think my own bias is with hands-on treatment, sometimes we're thinking of deep structures too often, and sometimes we don't need to aim any deeper than the skin, as the skin is actually probably the most richly innervated structure, and it's the thing we can actually touch. And I think there's a lot of value to that, personally, that light handling and creating a context where our bodies might feel more safe, allowing us to go into new positions, might be a good accompaniment to exercise. Hopefully that touched upon the question.
Very good. And then there have been a couple of questions that relate around either having had a bad experience with a physical therapist setting or a manual manipulation, a manual therapy, and having a higher increase in pain because of it, and kind of wondering what to do past that if you've had that kind of an experience.
Yeah, I think that experience matches up very well to what the literature suggests, and the research has actually shown that the average person with chronic neck pain sees an average of 6 different healthcare providers and has an average of over 20 visits. And that's an incredibly large number of things, but it shows that people feel the need to experiment with lots of different care. They find the need to both experiment with different types of treatment providers, but also within different providers within the same profession in order to find the therapeutic relationship that works for them. And I would say that part of that probably lies in that practice patterns aren't matching the evidence currently. So that may be part of the reason people are seeking care from different places. But the experience is a common one, I guess, is the summary of that, and I wish it weren't necessary, but perhaps if you've had a negative experience with a hands-on approach, taking something that, or seeking care from a provider that helps enable you to take a more active approach with exercises or with a self-management program, those might be things that I would lean towards if I were in that same situation.
Great. And then I have one specific question about, have you heard of the Bowen therapy?
I have, yes. I have heard of the Bowen therapy, and I would say that we include in our systematic reviews and overviews everything that reaches a level of a randomized control trial. Anything below that, we can't be overly confident in the results of the research, because it's not a controlled enough to really give us a sound answer that we can be confident in, that it won't change with another study that comes out the next week. And I may be mistaken here in not being up to date, but I don't think that there are any randomized control trials looking at Bowen therapy for neck pain. So I would say that that's why it's not discussed, is that it's not at a point in the evidence where we can make confident statements about that. I think scientific plausibility is really important to me in the explanation of things, and I think when we're talking about pain, I think the explanation of all of these different treatment approaches should involve the nervous system in the brain. If somebody's describing the mechanism of different treatment approaches as being aimed at the muscle or the fascia or the bone or the joints or the ligaments, I think we're missing a large piece of the puzzle, being the nervous system. And that's not, this is probably a tangent that's not meant to be aimed at Bowen, but aimed at all approaches, in that we have to think about the plausibility of how these things are working in order to be confident that they're having the effects that we suggest they have. And again, I think that applies to all hands-on or exercise approaches.
Very good. And then there's one
about...
a long-winded
answer to a simple question.
No problem. One about Botox injections for chronic neck pain, and do you agree that those this person has heard that there can be, that they can cause neck paralysis. I'm not that.
Well, what the objective of Botox is actually to paralyze the muscle that you're injecting it into. So that's the mechanism by which it acts. I have not had any cases of people that have the injection put into a place that's caused permanent paralysis or paralysis of muscles that they weren't aiming to paralyze. So I'm not sure about that happening. But I think I would look at the evidence and suggesting I think we can make fairly confident statements that for most people with neck pain, Botox isn't an appropriate therapy. That's not to say that that there aren't subgroups of people that we haven't identified yet that may respond to such a therapy. But if we look at the bulk of the evidence, I would say the majority of people probably wouldn't respond well to that type of treatment.
Okay. And then there were a handful of questions, and I think I might actually just ask you if you can email me some resources, and I can include that to send out to people. But a lot of people are asking about places where they can find neck exercises, like say they can't afford to go to a physiotherapist, or they, would like to do more on their own, that sort of thing. Any websites or other resources that you could recommend that people could access on their own? And so if you do have...
That's a tough...
Oh, go ahead.
Yeah, I think that's a tough question to answer in a group setting because exercises need to be individualized to some degree. But I'm happy to point towards what resources I do have for sure that I can provide afterwards.
That would be great. Then maybe I'll get that, and then I can provide that to all of the attendees for their knowledge as well. That would be wonderful. And then I think that's about it. I don't see any other questions that are pending. And also there is a therapist who's also asking for some resources for therapists specifically as well. So maybe we can...
So I'll include the clinical toolkit that I briefly referenced in one slide. I'll provide a link to that, and that should lead to a lot of resources as well.
Great. Wonderful. And then I'll go ahead and close up because we're right about at time. Thank you very much, Jordan, for your presentation. I think it was very wonderful and very informative. And just so everyone knows, there is an evaluation link in your follow-up email, and we'd appreciate your feedback. And if you have any thoughts on topics or things that are of interest to you for future webinars, please let us know. And our next webinar is Cognitive, Behavioral, and Acceptance-Based Approaches for Managing Pain. And this is featuring Dr. Matthew Graham, and it'll be on September 25th. So we'll be sending out an email for that sometime in the next couple of weeks, and we'd love if you joined us for that. Thank you again very much, Jordan. And we look forward...
Thank you. It's been fun.
Good. I'm glad. And we look forward to seeing all of you at our next webinar. Thank you very much.